Hello.
Hello, Mr. Kosti.
Yeah, hi, Bahru.
How are you? Good?
Yes, all ready. How are you?
Fine.
Hi, Bahir. Hi, Bahir. How are you?
Hello, Bob. How are you?
Fine. Looking forward to the event.
Yes, the last minute.
Yeah. Well, it happened.
It happened finally.
Yeah.
دكتور سمية، السلام عليكم.
أهلا وعليكم السلام.
كيف حالك؟
والله الحمد لله كويسة.
الله يعطيك العافية. ما بعرف، تقابلنا احنا قبل كده. أنا باهر غانم من الحكمة، برودكت مانجر الحكمة.
ممكن تعرف الواحد صايرين
الله
هسه
يعني. كيف
هذا.
أمورك؟
والله الحمد لله كويسة. أنت كيف أمورك أنت؟
بخير الحمد لله.
الله يعطيكم العافية.
الله يعافيك. يمكن حكى لك عبد الرحمن البروجرام هذا هو، يعني احنا حبينا to design program to share experience ما بين يعني أحد المستشفيات في كندا اللي هم ماكماستر يونيفرسيتي هوسبيتال وبين السعودي ترانسبلانت بروجرامز. حيكون 4 ميتينجز، هذا الأول منهم يعني في 4 سيريز. في كل ميتينج حيكون في يعني interesting topic to be covered، ويكون في discussion، ويعني hopefully to improve the outcomes, to improve the practices, to share challenges between different programs. فيعني we hope إنه يكون يعني ينال على رضاكم إن شاء الله.
إن شاء الله. أقول لك، طب هو كم مستشفى مشتركة التخصص؟
احنا عندنا من للتخصص الدمام، الحرس الوطني، الرياض، العسكريات، عسكري الرياض وعسكري الهدى. معانا يعني من اللي هي هذه المستشفيات اللي يعني مشتركين. هو حيكون الحضور من يعني اليوم 8 ل 10 أطباء من السعودية والثلاثة من كندا. يعني small design to improve discussion، لأنه لو كان الأعداد كبيرة ما حيكون في
أكيد أكيد. الله يعطيكم العافية
إن شاء الله. فإحنا بانتظار يعني 5 دقائق إن شاء الله ويكون الجميع موجودين.
طيب يصير أنا أستأذنك then I will come back.
أوكي براحتك.
أوكي شكرا.
بعد.
Hi, everybody. Good evening.
Hi, Dr. Travel. How are you?
Hey, Kosti. Nice to hear from you. I'm good, thank you. Hello, Dr. Ganji.
Hello.
Dr.
Hello.
Shravan.
Hi, Dr. Ganji. Nice to meet you.
Nice meeting you too.
My camera. Yeah. So we were still waiting for Dr. Ribik, right? She's
Yes.
she's
The
making...
invitation looked a little funny. I don't know if she is just clicking on it. But,
Yeah, if you click on the name, you can join.
there she comes.
Yeah.
Abdul Rahman.
Okay, if you.
Hello.
Hi, Dr. Ribik.
Hello, doctors.
Hello.
So it's always nice to have
Hello,
some
Bar.
former trainees here too.
Give me one moment. There's Dr. Altievi. Hello.
Hello, hello.
How are you?
Good to hear your voice, Abdul Rahman.
So
Oh
good
my
to
God.
see you.
I miss you all.
Oh,
Yeah.
We miss you too. We miss you too so much. This is really lovely. I know, Kosti, you're here on the line. I don't know how many people were thinking or joining. There's Mohammed Bukhari.
Bukhari. Hi, Mohammed.
Hi, Mohammed. How are
Okay,
you?
let's meet in the 7th floor.
Yeah. Yeah, you guys got used to that.
Yes, yeah,
Yeah.
that's right. So
I
nice
hate
to
to
see
tell you
everybody.
it's the same.
Honestly, it's like nice to see you all. We are missing you all.
It's
Yeah.
it's like you never, it's you now are back home, but it's like you never left. We can just pick up where we left off, and we're friends for life, right?
Yes.
Yep.
Indeed.
When Kosti approached us to do this, I think really the three of us, our main motivation was to be able to see your smiling faces one more time.
Yeah, the same here.
Because otherwise it's too hard to organize the time of day. You know, it's way beyond me. It's the truck.
All of us.
Ashokak is coming.
Hi.
Oh my God, the big boss.
Oh, nice.
Alhamdulillah.
It's so nice to see everybody. It's nice to have everybody out outside as well. So hopefully, Kosti, if you have a chance, I would love to maybe meet all the different individuals on Zoom today.
Yeah, there's Ali Al-Shakag. Hello. So maybe yes, Izzy, why don't we kind of get started a little bit? I agree with you, Izzy. Maybe we can go around and just introduce ourselves. Kosti, I'm gonna hand over to Dr. Ganji, but I just wanted to take this opportunity to say that we were thrilled when we got the invitation from Eurolink, Dr. Trelev, Dr. Ganji, and myself to come and have kind of a shared meeting with you to discuss interesting cases and practices. And we really, because we knew who was going to be here, we jumped at the opportunity to come. So thank you so much to Eurolink for setting this up. Dr. Ganji is going to be the MC of the event today. So I'm going to hand over the reins to Dr. Ganji, and then Dr. Trelev and I will be doing some presentations. This is going to be very informal, and we really hope that you'll jump in anytime to discuss anything that you have throughout the presentation. Really great to see you. And Dr. Ganji, I'm going to hand it over to you to kick off the event.
Excellent. Okay, great. Hi, everybody. Great seeing my former trainees, which is amazing. Great seeing the rest of you guys as well. So as Dr. Ribik said, we have a 2-hour session. I will occupy about 1 hour and 55 minutes, and I will try to give 2 minutes to Trelev and 3 minutes to Ribik as part of that.
Same guy. Usually you take the longest time, Dr. Ganji.
That's right, exactly.
Always a lot to say, right?
So,
yes.
So if it's okay, maybe we can just kind of go around and just kind of have you guys introduce yourselves to us actually before we introduce ourselves to you. So I'll go through my box here if it's okay.
If I may, Dr. Ganji.
Oh, yes.
Yes, this is Bahar Ghanem. I'm product manager at Hikma Pharmaceutical.
Okay.
And I would like to welcome everybody and thank you all for being here today. This idea we have been thinking about for at least 1 year, and it was not successful until we met with the Eurolink who made this possible. So thank you, Eurolink. The idea of this meeting is we have a roundtable discussion style meeting to share experience, share challenges. Transplant is always updating. There is always a new challenge in the transplant era. And we would like, as in Hikma, to be there and to support the continuous education, the continuous training in order to improve transplantation outcomes in Saudi Arabia and in the region.
You mute out.
We lost your voice.
Oh. Are you there still?
Okay. Bahar, we can't hear you.
I think he's on mute now.
Sorry, I think I had a technical issue. So anyway, the floor is yours, Dr. Ganji, and thank you again for being here with us today.
Excellent. Right. Thank you again, everybody. And thanks everybody for joining in. So maybe I'll just go around very quickly. And I'll start off with Dr. Al-Tiabi, who's first on my Hollywood Squares here, or or Riyadh Squares, something like that.
Yes. To introduce myself. Okay.
Yes.
I'm double A, as Dr. Rubik liked to say. I'm working now as a consultant transplant nephrologist in King Abdulaziz Medical City, and also assistant professor in King Saud University of Health Science. Currently, I'm the deputy executive for clinical strategy in the Ministry of National Guard, and your former trainee.
That's right.
That's the biggest thing.
Oh, you're so sweet. I love you. That's great. Thanks, Abdurrahman. Mohammed? Mobi? Better, more affectionate.
So, good morning.
Mobi.
I don't know, good morning, good evening, or whatever time is there in Canada. I can't remember anymore. I'm really glad, I'm happy, and I'm thrilled to see the three musketeers from McMaster. So I'm really happy to see you all. I'm Mohammed Bukhari, the formal name, or also known as Mobi. I'm a nephrology and transplantation consultant. Recently moved to Mecca, to King Abdullah Medical City in Mecca. But in the past 4.5 years, I was working in Taif University, affiliated with Al Hada Multi-Organ Transplantation Center, where I was doing most of my clinical practice. So yeah, here we are. Here I am.
Great. Thank you again, Mohammed, for joining in.
Thank
and
you.
then I have Ali. Al-Shagar.
Hello. Good evening.
Good evening.
Or good morning.
Good morning.
As
what is your hair, Ali?
He said, I'm ex-SHAC, ex-TRAC, ex-AS. I'm currently working as a transplant nephrologist at King Fahd Specialist Hospital, that's in the eastern part of the kingdom. Former nephrology program director, current transplant fellowship director, and definitely a former MAC graduate.
Thanks, Ali. Then I have Majed.
Good evening, everyone. I'm Dr. Majid Al-Harthi. I'm currently nephrology and transplant nephrology consultant in King Abdulaziz Medical City National Guard in Jeddah. I did my training in medicine, nephrology, and transplant in London, Ontario, between 2003 and 2009 or 10. And it's a pleasure to be with you tonight. And thanks for your invitation.
Great. Thank you, Majed. And then I have AAODEH. It's a different type of a double A.
Yes. So I think Abdurrahman cannot hear us. He's Hikma staff, Abdurrahman Auda.
Oh, okay. All right. Coca.
Hi, I'm from Eurolink actually.
Hi, Coca. Well, you can introduce yourself.
Nice to see you and to meet you.
Nice meeting you.
I'm one of the owners of Eurolink, together with my husband, who is iPhone XS Max.
Yeah.
Here. Yeah.
That's great. Thank you for sponsoring this event.
Everyone.
Appreciate it.
Yeah. Thank you very much for
Good luck.
being here. And good luck with the event.
Thank you. And then I have Ahmed.
Hi, this is Ahmed Al-Hindi. I'm the medical manager of Hikma KSA. Thanks everyone for accepting our invite. I work with Bahir. I'm looking forward for this very exciting meeting. Thank you again, guys.
Great, thanks, Ahmed. And Dr. Sumaya.
Hi, this is Dr. Sumaya Skandrani, former fellow from Cleveland Clinic. Currently, I'm working at transplant nephrologist with Dr. Ali Shaggag, head section of nephrology and CKD screening lead at Eastern Province, and also CKD educational lead at the level of Ministry of Health. I'm glad to be tonight with you guys.
Excellent. Great. Thank you, everybody. Thanks for joining in. So maybe we'll kick this off now, and I'm going to share my screen here for a second. Can you guys see this okay?
Yes.
Okay, great. So I'll start off by
we can see the slide sorter, Azim. I don't know if you want to go to full screen, but it's fine if you cannot.
I think I didn't sort it up, so you may not move. We can try it. Can you guys see it move?
No.
No. Yeah, that's what happens. Can you see it now, though?
Yes, we can.
Okay.
Yeah.
Okay, we'll just leave it right now. So it's my pleasure to introduce Dr. Christine Ribic, who's a transplant nephrologist and associate professor of medicine at McMaster University. So many of you already know her. She is the medical director of transplantation over here now, and also the AHA lab director at St. Joe's Healthcare Hamilton. She completed her master's in pharmacology at UFT, and then smartened up and came to Hamilton, and has been a valued colleague over here. She is completed a Master of Science in Health Research Methodology, as well as her pharmacology, as I mentioned earlier. She is involved in a number of organizations at McMaster. She is actually now the division director of nephrology at the university, and also the chair of the Trillium Gift of Life Network Asia Advisory Committee, and also plays a role in Canadian Blood Services with respect to paired exchange as well. It is my pleasure to introduce her, and you will hear from her shortly after I introduce Dr. Trelevin. So Dr. Trelevin, as many of you know, is an associate professor of medicine at the Division of Nephrology at McMaster. He completed his Bachelor of Science at McGill University in microbiology, and then did his MD at McMaster. With respect to transplant affiliation, so Dr. Trelevin was a prior director of transplantation at St. Joseph's Healthcare Hamilton, and is presently a lead at the Trillium Gift of Life Network. He is the medical director of transplantation for that organization, which is a provincial organization. He is also previously was the head of clinical services at St. Joseph's Healthcare Hamilton, so a lot of experience from a clinical perspective. And just briefly about me, so I wear more of an education hat, so I'm a professor of medicine at the university at McMaster, but also a VP of education of St. Joseph's Healthcare Hamilton, and involved in this as the chair of the CST Education Committee, and I'll talk a bit about that and hopefully get your engagement in that. As well as the chair of the Solid Organ Transplantation AFC Committee at the Royal College, and the Accreditation Committee of Area of Focus Competence. So As far as conflicts of interest go, so we've all been members of the advisory board for Astellas and Paladin Pharmaceuticals. As far as the formative sessions go, so we really want this to be interactive and really an open discussion throughout the entire session, okay? The way we've planned the session out is that we'll have a moderator for each session. So one of either myself, Dr. Rebecca or Dr. Shlevin. And within the structure, we decided to have at least 2 patient case reviews, and then we'll bring it to resolution at the end. We have some predefined objectives for each session. We'll forward you 2 relevant articles 1 to 2 weeks ahead of the session, so you have a chance to kind of review it briefly. But most importantly, this is really meant to be interactive and with open discussion. So please, just ask questions along the way. Raise your hand, and if I missed your hand, put your question in the chat. Whatever is easier for you, but please make sure that it is interactive. So it's because it is an exchange of information and a collaboration. So our plan is to have 4 sessions. So these are all Saudi time. So May 22nd, which is today, September 25th, November 13th, and November 20th are our targeted dates. Okay. And so we'll start with the first session. And the topic is graft survival and failure, interplay of target tacrolimus levels in HLA. And the overall objectives for this session are hopefully to consider the factors associated with graft survival and failure. What are our target tacrolimus levels that we should aim for? Intrapatient variability and how it affects allograft function. HLA factors influencing ABMR, memory response, and de novo antibody production, and consideration of donor-recipient HLA immune risk and target tacrolimus levels. Okay, so I think with that, I will stop sharing and hand over to Dr. Shlevin to start things off.
Just going to unmute here. Thanks very much, Dr. Ganji, and thank you, everyone. It's a long weekend here in Hamilton, and it's a time to spend with friends and family, and so it's an honor to be here and see your smiling faces. And I will say, for those of you that remember me, if the talk is going to be exciting, it's because I'm going to say something controversial. If any of my jokes don't seem funny, it's just that Dr. Ganji hasn't properly explained them. But I do kind of often use a lot of pop culture references, so feel free to call me on that. It gets quite fun. This is a lovely topic for a variety of reasons. One, if you're a company that makes tacrolimus, this is your dream session, because tacrolimus is the truck of transplant and it does a lot of heavy lifting. And so it really is a pleasure to do a better job of looking underneath the hood of the car of transplant and seeing, the engine of prevention of rejection, which is tacrolimus. And I really don't think we feature it enough. We've had a number of cases, Dr. Ganji, Ribik, and I, over the last 2 years. Hopefully, you guys haven't seen this. And so we've had a lot of discussion on this topic. And so we're happy to share it with you. Hopefully it makes sense. So we're going to start out with a typical case from the countryside, all the farmlands around Hamilton and London, for those of you that trained at Western. So this is a pretty simple case. I call this the world's simplest transplant case. And I'm sure we've had a dozen of these in Hamilton, and I wouldn't be surprised if we've had many of these cases in Saudi as well over the course of COVID. So to set the stage here, there's a 59-year-old gentleman. He's a truck driver. He was transplanted with a deceased donor transplant in 2013. It was an SCD-A donor, so not even I could screw that up. And things went pretty well. Background medical conditions were FSGS. There was no recurrence or anything interesting about this FSGS diagnosis in this whole case, Dr. Ganji. So you can stop thinking this is going to be a GN case, because it's not. He smokes and he has ongoing post-transplant polycythemia. And really the biggest work for 5 years in the transplant clinic was just getting this guy to do regular phlebotomies until 2020, when he smoked himself into an MI and had uneventful cabbage. really pretty easy patient under the surface to look after. So those of you that remember our time in transplant clinic together, we usually prescribe getting blood work done. I call it light blood work. It's really just simple blood work with electrolytes, kidney function, urinalysis, and a tacrolimus level every 2 months. I've gone to every 3 months, but for the purposes of this case, we should be thinking about every 2 months. And the guy's creatinine really never varied from 100 to 110 until he presents in December after not having gotten blood work done over a 6-month period, which was really quite common over COVID, which is what I meant in terms of this being a very common case. And so he shows up and his creatinine's 172. And of course, it was over our Christmas holidays. And so by the time we repeated this in early January 2022, his creatinine was up to 268. So this was a kind of a typical case. From here, it got a little bit complicated. We wanted him admitted for biopsy because I thought he had not been taking his transplant medications in addition to not getting blood work done. And so we just assumed that he had a rejection. There were no beds, and he sat in eMERGE waiting to get biopsied on Monday. He kept saying, I want to go home, I want to go home, I want to go home. And sure enough, on Sunday night, they let him go home, but not before they gave him Plavix, which he actually wasn't taking, but they just thought that he should be on Plavix, gave him Plavix, and then booked him to come back to the emergency department on Monday. And Dr. Ribic and myself saw him on Monday. Dr. Ribic, of course, noticed that he had been on Plavix. And so again, we couldn't biopsy him, so we had to delay the biopsy until sort of the second week of January. He did get a biopsy, and not surprisingly, it showed acute T-cell mediated rejection. It was BAMF grade 1B, and it was actually mixed cellular and humoral rejection. Of course, there was a little bit of everything in it. We have a new transplant pathologist who actually is very perceptive and sees all of these problems. There was FSGS, there was IFTA, there was C4D staining, in addition to the cell-mediated rejection. And Dr. Ribic organized DSAs, and for a nice change of pace in the lab, there was a whole lot of DSAs, and there were both class 1 and class 2 DSAs, including DQ DSAs, which Dr. Ribic might talk about later. So he got back to the hospital. We gave him pulse steroids. You guys all know this particular song. He received ATG, he received Plex, he received IVIG. And because his creatinine was so elevated, we didn't do anything else. And then he was discharged from hospital to be seen in clinic with the nephrology fellow with me. He gets seen in the nephrology clinic. Just to remind you, typical medication list. Now he's taking aspirin, he's taking 80 milligrams of furosemide. He's now on full dose CellCept, a gram BID. He's taking sodium bicarbonate, 1.5 grams 3 times a day. He's on Envarsus, taking 6 milligrams a day. Oops, sorry. And then, I just wanted to point out that he was on 60 milligrams of prednisone. So he came in to see me. Of course, he had raging thrush. He was half dead. And I saw him over a 2-week period. His creatinine went from 350 when he was discharged to 400 a week later to 550 another week later. And eventually I just gave up and referred him to his community nephrologist, who promptly started him back on dialysis. So ACR was negative through this, despite his original disease and despite the rejection. I don't think we're going to talk about that right now, but really pretty uneventful. And so I call this guy, the most typical rejection that we see over the last couple of years, especially with COVID, where people have been doing their blood work less frequently. And so, it came up in clinic. Everybody just shakes their head like, oh, what a shame. They say, what's wrong with this person? Did he get busy? Is he depressed? Is it COVID? Is it non-adherence? Why didn't this guy take his medications? Why is this man so silly? Why did he do this? And I put a little quick quote in Latin. I don't speak Latin, but the translation of quis custodiet ipsos custodes always makes me think, if you're saying somebody is making a mistake, and you keep saying that over and over again in transplant clinic, who's making the mistake? So who watches the watchman? So I think we're going to spend a lot of time talking about tacrolimus formulations. I'm the least qualified to speak about this, so I'm just going to show you some pictures. I summarized this for another case, but essentially I think it's very important to have as a background. We all understand Prograf was the first formulation of tacrolimus. It is an intermediate release formulation of calcineurin inhibition. It's dosed twice a day. It has a relatively shorter half-life, variable between 3 and 36 hours. Advagraph is the extended release formulation, available about 10 years ago, dosed daily, 36-hour half-life. A lot was made of Advagraph being an improvement on Prograf because of this extended release, allowing a longer half-life, perhaps allowing a little bit more leniency for adherence, perhaps making it easier for patients with a one-day formulation. And then the newest version of this is Envarsus PA, just to be inclusive. This gentleman was taking Envarsus. It's a prolonged release formulation with a very novel chemical matrix that has a bit better bioavailability compared to Advagraph. Dr. Ganji is going to go into this in future sessions. Some theoretical and probably real improvements in terms of some of the side effects associated with tacrolimus. Not a major feature today, but we could talk about dose changes using these different formulations. So we receive in Hamilton a whole variety of messages from our lab systems about how to dose tacrolimus. So these patients are seen, for example, at the Hamilton General on the top left, or at St. Joseph's Healthcare through our computer system. And it probably looks like your computer system because it's really just printing off from the product monograph. You know, whether this is right or not, it says it's a therapeutic range based on a 12-hour trough. If you're within 3 months of post-transplant, it gives you a little bit of electronic coaching and tells you to aim for 10 to 20 nanograms per ml. And if you're after 3 months, it says you should be using between 5 and 15 nanograms per ml. If you get this done in the community, you get a little bit more information. You get a little bit of reporting from the patient as to when the last dose was and when the test sample was taken. This is quite handy. And then at the very bottom where it says table 5, it's just actually the only real guideline consensus on how to dose Advagraph in the adult kidney transplant patient population. It recommends between 0.15 and 0.2 milligrams per kilograms per day for initial dosing. And then it has targets that are quite similar, with the targets of 7 to 16 nanograms per ml for the first 3 months, and then 5 to 15 nanograms per ml afterwards. So really very broad targets. When we're talking about trying to get tacrolimus dosing right, I had input from Kathy Berger and Simi, if you guys remember, our amazing St. Joseph's program, transplant program pharmacists. Administering Advagraph with food can decrease absorption by 25%. So recommendation that this be consistent, but preferably taken without food. Advagraph changes are slower to alter trough blood concentrations than Prograf. The half-life is 24 hours and steady state is achieved after 4 to 5 half-lives. So remember that your levels will be lower for a period of time. And then Simi said in particular that think about cyclosporin. If patients are on this, it's at least twice as difficult to target accurate troughs because of the different ways of measuring trough levels, C0 versus C2. There's a lot of variability in cyclosporin, as you'll see. There's complete disagreement on what levels are adequate within these different trough ranges. And there's a large relative decrease in MPA availability as you're switching around with cyclosporin as well. So If you do switch back to Avrograph, for example, it may take 4 to 5 days to reach appropriate levels when you're switching back. So a lot of caution must be taken when switching between these medications. And I don't think we all think about this much. And this will be relevant later. Azole antifungals are the most commonly co-administered drug that reliably increase TAC levels by 50%. And conversely, when you withdraw the antifungals, it decreases the TAC by 50%. And that's because it also inhibits CYP3A4 and P-glycoprotein. So bear that in mind. So what information do we have from our societies about how to dose calcineurin inhibitors? Well, this is the one paragraph in the Kidney Practice Guidelines for the Care of Adult Kidney Transplant Recipients, published in 2009, reviewed by both the AST and the CST, and really not a lot of information except it lists the product monographed. It says that high doses can be associated with adverse events, and low doses might increase your risk of acute rejection. And then it lists the original trough level targets, and then it lists the Symphony trough level targets, and it actually puts a number to it. So the trough level based on the original product monograph at C0 was 10, and the trough target as specified in the interpretation of the Symphony studies is 5 nanograms per ml with a range of 3 to 7. So really quite broad, and then it gives some information about cyclosporin as well. So let's look at Symphony briefly. So Symphony, as you recall, was a randomized trial, a large randomized trial, whose main goal was to minimize calcineurin inhibitors. So there were 2 arms looking at different trough levels of cyclosporin. There was a low dose tacrolimus, which ended up essentially winning transplant based on this study. And then there was a 4th arm looking at sirolimus as well. And these were very well SCD donors. The mean age was 45. 37% of these participants were living donors, and the average creatinine clearance was 65 mils per minute, which is really pretty phenomenal. And the acute rejection rate in this low-dose tacrolimus arm was about 12%, despite the fact that they didn't have the benefit of all of the antibody screening that Dr. Ribic and the HLA lab now provide for us, and I'm sure are provided to you now. So, you know, everybody else was seeing rejection rates in the 25 to 30% range, and this, you know, sort of dark horse come from behind combination of low-dose tacrolimus with basiliximab induction and CellCept had about half of the acute rejection rate. And if you look on the right side there's a follow-up paper that was published in 2009 by authors that really did a more meticulous job of documenting exactly where the trough target levels were in participants relative to the target levels. So you can see the target levels in the black lines. You can see the 25th and 75th percentile, and then you can see, frankly, every single dose that was given in every single week to the participants in the tacrolimus arm. And you can see for the most part, they landed on the higher side. So if you rack that up and you simply say how many of these weekly measurements were above target compared to within target compared to below target, on the left, you can see the tacrolimus arm really ran away with avoiding below target trough levels of tacrolimus. And then if you look at the standard dose cyclosporin version on the right side, you can see that there were many options, many occasions here where the cyclosporin arm participants were below target. And on balance, Symphony patients, and this was like considered, I think, one of the sort of more weak parts of the trial, people would say, well, Symphony is kind of hard to interpret because, you know, the low dose tacrolimus arm spent very little time with low CNI levels. And in fact, they had targets that were on the higher end, closer to 7 nanograms per ml than to 4 nanograms per ml. So, you know, let's jump right into it. You want RCT data in transplant. We're going to give you RCT data in transplant. So it wouldn't be a McMaster presentation without some of this very high level evidence. And in fact, since 2015, there's been 3 informative trials that have looked at what are the clinical outcomes in a randomized circumstance once you either lower or eliminate calcineurin inhibition with tacrolimus. Let's go. You can see I'm foreshadowing here. This fellow is not going to do well, and neither are the participants in this trial. So the first study that was stopped early of this batch of really quite unfortunately designed trials is got a lot of Canadian content. So this was David Rush's group inputting and working with collaborators in the American Midwest. And they designed a clinical trial meant to look at 300 patients that were going to, after, I believe it was after 6 months, identify individuals who did not have DSA, they had not had rejection, they were very compliant, they had normal protocol biopsies, and there was no difference in GFR. And they randomized the first 21 subjects either to withdraw from tacrolimus or to continue on tacrolimus. The group that continued on tacrolimus did pretty well, as you'd expect. There was a DSA or two. But in the tacrolimus withdrawal group, as you can see down on the bottom, you can see the little X there is the time they stopped, and anything colored. So they finished their withdrawal. I forget, what pace they withdraw their drug, but it looks like it was over a period of 100 days or so. Once they finished their little withdrawal with the green X, they started having outcomes. So the outcome was either DSA or rejection. So they actually ended up, unfortunately, having to stop this trial. They reported this trial. It was in JASN in, I think, it's 2015. But it really, I think, was quite the warning. It was really meant to say, despite Symphony aiming for these low dose studies, you probably don't want to go any lower. And really, they sort of thought, as a result, there was a strong argument for continuing with tacrolimus. This is another study, another large study that looked to withdraw calcineurin inhibition with tacrolimus in stable patients after 4 years, or sorry, after 4 months. And the idea was to cut the dose in half cut the dose by a third every 2 months. And again, 100 patients were planned to be enrolled. They enrolled 10 patients, and they had another very poor outcome. So in the placebo arm, the ones that did not have the tacrolimus withdrawal, they all did quite well. There was 1 episode of DSA. In the group that was targeted for this gradual withdrawal of tacrolimus, they again saw many episodes of de novo DSAs and acute antibody-mediated rejection. Finally, in another RCT, this time from the Paris group, they simply randomized the group to 50% of the prior extended release tacrolimus formulation trough. These were in patients that were off prednisone. Again, they had no DSAs, and they were anywhere between 4 and 12 months post-transplant. The idea was whether or not they could go lower than Symphony targets. So there were almost 100 patients in each of the group. And you can see that about 83 patients were randomized to withdrawal, and 97% of them continued on. You can see what these trough level ranges look like. So pretty equivalent in month 0, a bit slow to fall in month 2. The green here are the half dose group after randomization, and the blue is the lower trough groups, the green are the higher trough groups. So the higher trough groups are just continuing, and the blue get down pretty quickly down to 5 nanograms per ml. There's no difference in GFR, so this didn't really seem to make any kind of difference with regards to the renal function when you compare this group. But again, it was stopped early because of an abundance of DSAs that were apparent in the lower or 50% trough target group, with a correspondent increase in the number of acute rejection episodes occurring in this group. So again, stopped early. So this was published by the Paris group in 2017. Again, the most major output from this study was to be very cautious about dropping tacrolimus levels below 5 nanograms per ml, which seemed to be the danger range. There were no rejection episodes in any of the participants if the tacrolimus level remained above 7 as a mean target. So I think we've got a message here. We've got a very complicated drug to use. And instead of having a very precise algorithm to handle dose changes and to keep this therapeutic but dangerous drug in the right range, we have this incredibly simplified nomogram. And so if heparin was handled like tacrolimus, the heparin nomogram would be simply, instead of the complicated, precise figure on the right, it would be Dr. Treleven's suggestion that you keep the PTT somewhere between 50 to 150. By the way, there's multiple versions of heparin for you to choose. You should think about checking the PTT again, either if you make a change or sometime in the future. And otherwise, good luck, and I hope you don't have bleeding. So that is unfortunately how we handle tacrolimus. There has been a lot of effort to try and improve this. We've got colleagues at McGill that are working on this, and this is from a review article by Ruth Pira-Shade. And this shows two patients. The patient A in white has a typical measured set of tacrolimus trough levels, and they vary between 4 and 8 nanograms per ml, but they only vary in a very tight range. This is in contrast to patient B. Patient B's levels are all over the place. There's difficulties with timing, there's difficulties with dosing, and as a result, the variance in patient B is about twice what you see in patient A. And when the folks at McGill follow these individuals out, unsurprisingly, they have a higher rate of rejection and a quicker rate of graft failure in observational studies. Typically, this is shown as pretty simple formula for calculating the coefficient of variation, which is essentially the standard deviation divided by the mean times 100. You can either do this for, add up all the variances from the mean and simply add them up. It's probably a little bit less accurate, but you can also just divide the standard deviation by the mean for any given patient over a period of time, and for that period of time, get an estimate of the coefficient of variation. So I did this for our patient, and my patient had a mean of over a 4-year period prior to his presentation with rejection. The mean was 6.2 nanograms per ml. The standard deviation was 2.5 nanograms per ml. And the coefficient of variation, or the intra-patient variability for this individuals, was about 40%. I just want to point out, I couldn't really clip it all in because of privacy and technological failures on my part, but you could actually see, as you look at the long strip of this patient's blood work, as many of you guys have done with me, and you can see that, for example, in year 1, this individual did 6 out of 6 blood draws. In year 2, he already dropped down to 3 out of 6 blood draws. And I would call this the Ribbick alert, because it's super simple. And we all know when this happens in transplant clinic. Interestingly, he only did tacrolimus correctly about 80% of the time. About 20% of the time, he would have forgotten and taken his medication within 4 hours of the blood draw. So he would go and do blood work, but his blood work included fresh tacrolimus administration about 20% of the time. So this is another, I would say, very super simple marker of people that are having troubles, and I call this the Ganji alert. The Treleven alert I'm saving for the number of times exactly this guy's tacrolimus was lower than 5, despite me being pretty strict about prescribing it between 6 and 8 nanograms per ml. You guys know I'm not very strict about very many things, but I am strict about this. And this guy's tacrolimus was below 5 40% of the time. So I really think this is apparent. This guy's creatinine over a 5-year period, same lab work. Creatinine was always between 90 and 100. We'd look at it, we'd feel relieved. The ACR was done, no proteinuria, really no other lab work abnormalities other than the hemoglobin being elevated. And so high intrapatient tacrolimus variability has been looked at by a number of different groups. I'll just highlight 2 of them. This is the UK group. So these are observational studies. So these guys in 2017 looked at 430 patients over a 4-year period. They simply divided up the patients as to whether or not their variability or coefficient of variation was above 15%. About half of them were, and those individuals were at higher risk of graft loss, with a hazard ratio of 4.9, which is quite high, as you'll see. So they compared that to other things with regards to the risk of graft failure over a 12-month period. So in this situation, the variability was 4. The odds ratio was 4, and that is compared to an episode of rejection where the odds ratio was 3. Delayed graft function, something we've all spent a lot of time talking about as we admit patients and discharge patients, is only 1.5. So really, this is quite a dramatic thing to be overlooking in clinic. Finally, this is another group out of Colorado. This is David Smith and Alex Wiseman, who looked at the risk of de novo DSAs, and Dr. Ribic is going to talk about that, simply dividing the groups up into their demographics prior to the de novo DSA development. And again, not surprisingly, low trough, mean trough levels of tacrolimus are associated with an increasing risk of donor-specific antibodies and graft failure. They've looked at this as well, looking at time and therapeutic range. So time and therapeutic range is as a corollary. It's just the proportion of blood draws that are within range versus the proportion of blood draws that are out of range. And it's similar to studies where they look at the effect of warfarin on INR and look at different strategies for trying to keep it in range. Again, very high rate of de novo DSAs, risk of acute rejection, and a risk of death-censored graft loss in this group of 400 patients from Colorado. So I think one of the articles that we included for you was this comprehensive review of the impact of tacrolimus inpatient variability on clinical outcomes in kidney transplantation. And I think this figure will provide a map for some of our further conversation. So kidney transplant recipients are varied in terms of their daily habits, their food and drug interactions. There are genetic factors that are both apparent and not apparent. There is medication non-adherence, which I would argue is very apparent. And then there are problems with concomitant illness like diarrhea, and even problems with concomitant illness that are not necessarily associated with variability in the patient's bioavailability of tacrolimus, but that might, for example, lead to hospitalization, that might lead to changes in drug dosing or drug measurement. All these contribute in the center to high interpatient variability, and this leads to acute rejection, de novo DSAs, and typical histological lesions like interstitial fibrosis and tubular atrophy that lead to graft loss due to immunological and not calcineurin inhibitor toxicity. So in this review, they pose several open questions. Does high tacrolimus harm grafts in itself? Is high interpatient variability simply a marker of non-adherence? Is high intrapatient variability modifiable? And if it is reduced, will outcomes improve? So finally, the last part of my talk is to highlight a few things about graft failure. So many of you know this is one of my favorite articles of the last 10 years. This is a review article that both looks at the prevailing problem of consistently high rates of graft failure, no matter what era you choose. From 1989 to 2010, the 10-year death-censored graft survival rate is really basically unchanged. It's improved a little bit, but it really is not that different than if you had received your transplant in the 80s, despite all of the advances in drug monitoring, immunosuppression, and immune testing. Most cases of graft loss, when you look at biopsies, can be characterized, and many of them have links to the immune system. So graft loss due to medical or surgical factors are really only about 18% of the time. 5% of the time it's unknown. 9% of the time it's acute rejection. 41% of the time it's glomerular disease, which may also be in part due to rejection. And then 27% of the time it's chronic, and you simply see fibrosis and tubular atrophy, which I think most of us now would attribute to chronic antibody-mediated rejection. This is a construct from a review article in CJSON. I think it simply puts us all on the same page to say that there's many inputs into this: recurrent GN, AMR, cellular rejection, BK. on top of these chronic stresses from diabetes, hypertension, vascular disease, some component of calcineurin inhibitor nephrotoxicity and obstruction. But for the most part, all of these injury mechanisms work on damaged, older tissue that only has so much capacity for repair before you get graft failure. Phil Halloran, I think, has the best construct of this. His group and the DCAF group in the American Midwest have done multiple studies now. There's probably 2 or 3 dozen publications on this, looking at different ways of considering for-cause kidney allograft biopsies and what you see in terms of histology, what you see in terms of gene expression, and what you see in terms of effector protein expression. And really, most of these end-stage leading to graft failure biopsies are characterized by antibody-mediated rejection, markers of glomerulonephritis, IFTA, and otherwise pictures of mixed rejection, with very few grafts being lost in the long term due to calcineurin inhibitor toxicity or polyomavirus. So are there counter arguments? For example, are there reasons to lower calcineurin inhibitors? So historically, people have made a lot of concern about the potential to worsen diabetes, worsen hypertension, or provoke hypercholesterolemia in patients being treated, for example, with tacrolimus. I would argue that all of these endpoints are relatively minimized in our transplant group relative to rejection and graft failure. All of them have other treatments that we're all quite expert in applying, and none of them have quite the same one-way trip as what you see from low trough levels. And all minimization trials have shown an increased risk of rejection, not just the ones I showed here. Is refractory BK or severe COVID reasons to decrease calcineurin inhibition? Probably in the case of BK. COVID, it's not clear yet. I think we may be a few years of sorting this out. Up to Date recommends when you admit a transplant patient with sepsis holding the calcineurin inhibitor. This is Dan Brennan's card in Up to Date. I'm not sure exactly what data set he's referencing, but there's actually data now coming out of, for example, the ID group at Duke University that showed individuals admitted to the ICU with sepsis, either because of gram-negative bacteria or Staph aureus bacteremia. Some of these patients on calcineurin inhibitors actually even do better in terms of leaving the ICU and 30 and 90-day all-cause mortality. So I think that's time for another journal club. But I think it provokes this question where we should be looking at the numbers and not necessarily just our medical school concept of physiology and taking for granted what everybody has always told us about calcineurin inhibitors and how dangerous they are. I think all of these things need to be challenged with data. So for this portion of the talk, thanks for your attention. I hope I haven't gone too long. I would say missing and low tacrolimus levels are common in outpatient transplants. There's a lack of precision around appropriate trough levels for tacrolimus dosing from the original product monograph, our guidelines, and even the single most important RCT in kidney transplant, the Symphony study, is very broad. Recent RCT data on tacrolimus elimination is uniformly dangerous in transplant recipients, and the observational data suggests that kidney transplant recipients with high proportion of the coefficient of variation or low time and target range are at risk for harmful immunological events. Thank you. I'll now pass back to Dr. Ribic and continue with another case afterwards.
Maybe before we just go there, Darren, just wondering, does anybody have any questions or comments on some of the slides Darren presented? No? Oh, Mohammed?
Dr. Bukhari.
Yeah, thank you, Dr. Sullivan. Very interesting talk and very comprehensive, actually. So, I mean, what I see commonly in my clinic is when the patient is on minimal dose of Prograf. I mean, Prograf is the most of the time is the available form of CNI of tacrolimus. When the patient is on low dose of tacrolimus, 0.5 BID, and despite that, still having high tacrolimus level. I mean, what's your insight in terms of what I should do in these cases? Because most of the time, if the creatinine level is stable, if the patient is stable, there is no clinical or biochemical manifestation of CNI toxicity. Most of the time, I think it's I get hesitant to reduce the dose further. So, what's your insight in these?
What are the trough targets, Mohammed?
Well, patients who are like years post-transplantation and their tacrolimus is 8 or 9, in that range, still it's
and they just have something either for metabolic reasons or, you know, hepatotoxic, you know, steatohepatitis.
I mean, we see this. At least I see this in my clinic quite in few patients, like in 4 or 5 patients. Patients who have tacrolimus level, high tacrolimus level with no clinical or biochemical manifestation of CNI toxicity.
That's, I would say, the majority of the patients I see. And I mean, I think Dr. Ribic is going to give you a little bit more information in thinking about the matching state in that person as to whether or not it's a risk or not. The one thing I'd say about low tacrolimus dosing causing acceptable levels, the one thing you're at risk for is you're not having a good convention around how to reduce that safely. And, you know, the lower down you go, the more chance there is if that person is admitted to another hospital where they make some change. And, you know, you could drop those levels quite significantly with small changes unless you do it in very gradual increments. I think, you know, Dr. Ribic, Angie, and I have done this with with some patients by putting them on liquid tacrolimus and using that to get, you know, either diluted or not diluted to go down in sort of more appropriate increments. But I think the danger is just that, you know, people that would be less thoughtful than you would just drop it thinking the levels are high, for example, if they're admitted to hospital.
Yeah, I mean, I tried once to switch the patient to Advograph, knowing that Advograph, the area under the curve with Advograph is lower than Prograph. But unfortunately, I couldn't provide the patient with Advograph for a long period of time. So I didn't want to switch him from Advograph, like between Advograph and Prograph back and forth. So basically, most of them now on Prograph.
Yeah, why don't we can come back to this with Dr. Ganji. I mean, for me, your levels are acceptable, and I think the danger is messing with them. I think I'd be perfectly happy with that individual in that range.
Yeah, I mean, we can talk about that in Mohammed, maybe the pharmacokinetic section, for sure, and see how we can play with that.
Sure.
For sure. Sultan?
I think Dr. Sultan raising his hand.
Yeah, yes.
Assalamu alaikum. I think good afternoon for you. I have one patient actually with a very low level of tacrolimus. His FK level from 2 to 3. I don't know what to do for him. He's now 20 years transplanted. His creatinine is very good, no proteinuria. I keep him at the same dose. This is my plan. What do you think a good plan for him?
So, Dr. Alhazi, you mean to say that the trough levels are low or the dosing is low?
It is the trough level for this patient. I inherited this patient from other clinic, and he had very low level of FK, but acceptable creatinine level, no proteinuria. He's doing fine.
Yeah, I think again, I'll defer to Dr. Ribic to show you what sharks might be swimming under the surface of the sea. But, you know, I don't know that you'll know. I mean, the person could be identically matched and you could be fine, and they could be fine in steady state, or if they get a virus or they get hit by a bus, and, you know, that person changes, their cytokine exposure changes and their HLA expression changes, and then those levels are no longer protective. But without knowing the degree of mismatching, you don't really know what you're doing. So it's a great it's a great example. But why don't we let Dr. Ribic refer back to that case.
Yeah, Dr. Alhaza, it would be really interesting, if you are thinking of coming to subsequent sessions, maybe if you could get the DR and DQ matching on that patient, because maybe it's going to help illustrate a point, which is, it's like I planted this question right here to kind of look at the next steps, because we know that in people that don't have a high epitope mismatch at DR and DQ, they can sometimes get away with low levels of TACRO. Not that we're going to say that you should run them low, but they can get away with it sometimes, and as Dr. Trelevin said, all they need is some other immune stimulating event where something can happen and then things go off the rails. But it's just interesting to see, and we've had patients like this too. I had a patient who came to me and said, Dr. Ribig, I have to tell you that I have not been taking my Prograf twice a day. I inherited this patient early on in my career. I've only been taking it once a day for the last 10 years. And he's now 20 years post-transplant and his creatinine's 100. And I just say, okay, well, that's okay, I guess, but, the question really is, how do we individualize this? And this leads us really nicely into this portion of the talk. So I'm going to start sharing my screen. And if anyone has questions throughout this talk, please do just reach out and you could even ask throughout. Now, are my slides advancing, Dr. Ganji?
They are.
Perfect. All right, so let's jump into this. So it's, I want everyone to kind of stretch, kind of clear your minds for a little bit and get ready to jump into some exciting information that's going to really build on what Dr. Trelevin so nicely presented to us. So we're going to talk about how this concept of targeting tacrolimus levels really is interconnected with immunological risk assessment in our patients. And it really isn't one size fits all for our patients. And in fact, as we're learning more about how to actually determine immunological risk, we're learning about which factors may actually influence increased risk of graft loss or de novo DSA production. And de novo DSA production is really the key that leads to chronic inflammation, graft dysfunction over time, and premature graft loss. And that's what we're really trying to prevent. In transplantation, that is one area that we're really trying to improve, is try to extend the life of our allograft. So let's jump right into it. So as a disclaimer, I just wanted to point out that for all of our speakers here today, the data is not related to any of Hikma's products. That may include medication not yet registered in KSA or with indications that are not yet approved. So, anyone that knows me knows that I get great pleasure in talking about HLA. And Mohammed Bukhari is smiling because he says, yeah, I know this. This is going to turn into an HLA talk. But this is pertinent. This is going to be very important here, because I'm going to kind of walk you through how we actually classify immune risk and how that classification ties in with tacrolimus levels. So let's get to it in the first bit. We do a lot of HLA testing, just like you do at your center. And the reason we do this HLA testing is we really want to kind of determine an immune threshold in our patients where we're going to say, yep, this patient is at low or standard risk for some type of rejection, and we're going to transplant them, or they're at high risk and we're going to either not transplant them or do something differently, either enroll them, in our case, in a national program, or perhaps even cross DSA. But, there's really other reasons why we want to look closely at HLA testing. And really, it's really to try to determine how is this person going to do with this allograft in the long term? What is their potential for immune memory and de novo DSA production, which would lead to early graft loss and potentially rejection? We want to use some of this data, and we want to see whether we can actually tailor how we induce people at the beginning of transplant, but also how we maintain them long-term and what tacrolimus levels we can target. And lastly, we want to provide individualized counseling regarding immunological risk to our recipients, and not just a one-size-fits-all for everybody. And we all know that there's various phases of testing that we do. We do pre-transplant testing, where we do typing for the donor and the recipient, antibody detection with PRA and antibody identification. We do testing at the time of transplant, which includes antibody specificity testing again, and then flow T and B cell cross-matching. And then after transplant, either for cause or for monitoring, we will look at post-transplant monitoring, where we're looking for any de novo DSA. This is is all in the construct of transplanting people that do not have a DSA prior to transplant. Of course, you know, many years ago, we also, we used to cross DSAs, and even now in Canada, we're looking at instituting a willing to cross program again in people that are having a hard time getting a transplant because of CPRAs of 99 to 100%, but that's not what we're talking about here. We're talking about people that go into transplant without a DSA that have, you know, immunological risk that is acceptable to proceed. Okay, so when we think about this immunological risk, what are we actually talking about? And I'm going to kind of present a construct that is, you know, something that we're using here now in Ontario and actually rolling out across Canada to think of immunological risk in 3 different areas. And the first is hyperacute rejection or early antibody-mediated rejection. So when you're on service, when you're on call, when you're seeing your patients, we really are looking at cross-match testing, and we're looking at any testing that was done to look at antibody identification. And if that patient is negative for DSA, and if they have a negative cross-match, or if they have a positive cross-match without a DSA, because it's either non-HLA or autoantibody, they are standard immune risk for early acute rejection. I'm talking about rejection right after the OR or rejection in the first 90 days. That's standard. Intermediate risk is where they may have a positive DSA, but a negative cross-match. So in the past, maybe they had a positive DSA. We don't think that they're going, but the cross-match is low, and we know it's low-level DSA. We don't think they're going to actually have rejection right away, right after transplant, but they are at a higher risk than someone that's standard risk. And high risk is really where you have a positive DSA and you're doing an HLA incompatible transplant with a positive cross-match. All of these tests are only telling us what's happening at the time of transplant. We are all going to be targeting high tacrolimus levels, inducing our patients, using steroids, using an antimetabolite. So there's not much difference in the way that we're treating people here, other than if we're doing HLA incompatible transplants. That's not really what we're talking about with de novo DSA production. What about the second arm of immunological risk? Memory response. So here we're talking about whether that individual who currently doesn't have DSA would be at risk of actually developing some type of memory response from a sensitizing event. And how do we assess this? We assess this with antibody identification testing. We look at CPRA. And if they have no sensitizing event, nothing in the past, and they have a 0 CPRA, they're at standard risk for developing a memory response. If they have any PRA greater than 0%, or they have a known sensitizing event with a greater than 0% PRA, or they have a sensitizing event and we only have a few samples, meaning that we tested them, you know, now, let's say today, and they had a pregnancy 30 years ago, they would still be at risk, intermediate risk of memory response, because they were exposed to something that would increase the risk of having a memory response. And high risk is really where they have a historical DSA or current low-level DSA. Not only are they going to have a memory response, but they're really at high risk because we know that something is there. Sometimes people think that we should tailor immunosuppression based on the CPRA. And what I'm going to show you is that, you know, the way that we assess memory responses through 2 tests. We said PRA and an antibody identification. And I'm going to show you that CPRA itself does not predict for de novo DSA production or how we should tailor immunosuppression. Let me explain a bit further. This is an antibody identification screen. You can see that there's a lot of red antibodies here. And these are things that we would call antibodies. We can't call them DSA because we only call them DSA when we have the donor typing to say whether it's DSA or not. We then put it into a calculator. And every time we run that antibody identification test, we put it into a calculator called a PRA calculator. This is the Canadian PRA calculator. And by the way, this is something that was established here. There's one in the US that does not include DQ alpha, DP alpha, or DP beta. This was established here in Canada. And there's one of your colleagues in Saudi is actually looking to move this over to Saudi as well to use this. This is free. If you Google Canadian PRA calculator, everyone can use this. So we put in the antibody identifications into this calculator, and we're able to calculate what the PRA is. And what research has found, what many groups have found, but here's just one publication in AGT from 2017, which looked at multiple transplantations with various levels of CPRA. So they had patients represented from CPRAs of 0 all the way up to 100%. And they followed these patients for up to 6 years. And what they found was if you look at the cumulative percentage of CPRA on the y-axis and the risk basically of them having basically their CPRA, what their CPRA would be, you can see that those that had no sensitizing events in general had a lower peak CPRA than those that had a sensitizing event. And that's, you know, we would think that that makes sense. If you haven't had a sensitizing event, your CPRA should be lower. And the people that had the highest CPRA are those in blue and black that had either a peak or last CPRA the highest if they had a prior transplantation or a mixture of a sensitizing event. And in the middle is pregnancy. So how does this correlate with clinical outcome if you have a high CPRA? What you can see is that whether you've had a mixture of sensitizing events in gray, whether you've had a CPRA that's as high as 100% in blue, or whether your CPRA is actually between 1 and 50%, so a range of CPRAs, there is no difference in antibody-mediated rejection, T-cell-mediated rejection, death-censored graft loss, and graft survival. The only thing that was different was if you had a pre-transplant DSA. So why, we all know this here. Why am I showing you this? Because sometimes people seem to gravitate towards the idea that if you have a high CPRA, even a CPRA of 100%, like these guys in blue everywhere, that for some reason, those individuals now are going to be at a higher risk of rejection. And the truth of the matter is, as long as they don't have a DSA pre-transplantation, the rejection risk for all of these outcomes is actually the same as everybody else. And we can see that here in multivariate analysis as well. It's really pre-transplant DSA that will increase your risk by almost threefold compared to the standard population for having an outcome such as antibody-mediated rejection. But interestingly, there's also DR and DQ mismatch. If you have a mismatch at DR or DQ, your risk of rejection is also higher. And that's what we're going to dig into, because those are things that we may be able to modulate when we're picking potential donors for recipients, or at least trying to optimize their immunosuppression post-transplant. Okay. So summary of this section is DSA is predictive of ABMR, TCMR, and graft loss. And we've just talked about the memory response. So if you have a CPRA that's high, you might be at risk of memory response if you have a breach in immunosuppression, but that alone does not increase your risk of rejection. It's really, if you're an appropriate immunosuppression in the absence of DSA, that is not going to increase your risk. De novo DSA, this is the part we really want to focus on. So this is the third piece that we're evaluating through HLA testing. And what are we evaluating and what are we using to evaluate this? What is de novo DSA? De novo DSA is when a recipient receives a donor and they have no DSA to that donor. And over time, they develop a DSA after transplantation that wasn't there previously or didn't look like it was even there at low levels. So people that are at standard risk of developing a de novo DSA, a new DSA, a post-transplant, are those that have a 0 DR and DQ mismatch, meaning that they are perfectly matched at DR and DQ at the antigen level or at the epitope level. Those at intermediate risk are those that have any class 2 mismatch, particularly at DR and DQ or a high epitope load. And those at high risk of developing de novo DSA are those that are mismatched at DR and DQ and have a very high epitope load. So what is this epitope load? We all know about antigens. We talk about DR and DQ antigens. And when I talk about DR and DQ, I'm talking about DR beta 1 and DQ beta 1. What are epitopes? So let's look into that, and we're going to look at basically how we put this whole picture together, and particularly focus on de novo DSA as a predictor of potentially graft loss and antibody-mediated rejection in those particularly that have low maintenance immunosuppression levels of tacrolimus. So let's look at that together. So this is a very simple diagram where we simplistically think about an antigen on an allograft, and a T cell interacts with this antigen, and this stimulates a variety of cascades within the T cell to activate the T cell and then preferentially look at that allograft. And this is a simple representation. But what we know is that this antigen is actually very complex in that there's hundreds of base pairs that we're looking at that actually make up this particular antigen. So for example, if we're looking at the A locus, this would be denoted by the A locus for class 1. There's a different type, which is in this case A24. As soon as there's one amino acid substitution, this is now the allele of this A24, which could be either an A2402 or an A2401. If there's a silent substitution, then that's to the 6th level digit typing. This is differences outside of the coding region, so in the introns and not the exons. And then finally, the expression on the cell surface. So it's very complicated with many areas of this antigen being sequenced for us to actually ascertain how the patient is typed. And we know that it gets even more complicated in that, when we look at the antigen, we think of antibodies that bind to this antigen, and they don't always have the same names. So for example, a B14 would have a B64 or B65 binding to it. And when you look at your typing reports, I believe that it's the same for you now in Saudi like it is here in Canada and in many places across the world, is we get typing reports where we're really looking at the antigen. We are looking at this piece, this little antigen that's on the allograft, and we're typing it to tell you what it is. In this case, this is a B15 with a B62 antibody that can bind to it. But as you dig deeper into that structure, I said it's very complicated with several amino acids. What you find is that this antigen that we're showing on the allograft is much more complicated, with only a very small portion involved in binding to the T cell receptor. And that small portion that binds to the complementary determining region is called the epitope. And it's really the small little piece of the whole antigen that's responsible for that binding. So what are epitopes, and how do they interact with antibody? So epitopes are polymorphic amino acid residues that are really kind of like 3 little linear residue sequences that are found on the antigen binding domain. And they're surrounded by a variety of other amino acids that kind of expose them to the antibody. And this is what it looks like structurally. So here we have a functional epitope, this blue area here. This is the antigen. These are kind of the 3 or 4 amino acids that are surrounded by a structure of other amino acids that expose it to this antibody and the complementary determining region that binds to that area. And then recognizes through allorecognition, recognizes the allograft. Because these regions are exposed and because they can bind to antibodies, what I want to show you is that there are some regions that are more similar between antigens than we once thought. We used to think that an A24 was totally different than an A25. And now we know that they have similarities. And in fact, this is what we would call an epitope or applet analysis. Let's look at this together. I'm going to try to explain this in more detail. Here is an HLA-A1 antigen. I've shown it to you from the front, the side, and the top. There are 3 colored regions in here. There's a yellow, red, and green region. And each of these regions can bind antibody. Each of these regions can bind antibody. You can have 3 different antibodies that are going to identify this HLA-A1, but they may bind at different regions. Here is the HLA-A1 and the amino acid sequence for HLA-A1. And below here, I've listed through HLA Matchmaker. I just pulled this down through HLA Matchmaker. And I've shown you a variety of different antigens here. And what you can see is that where there's hashed lines, they're exactly the same as A1. But what you can see is that in these regions here that I've highlighted here, A62 to A67, A76 to A83, and amino acid 95 to 99, A23 and A24 are very similar. They're more similar than they are to A1. And if I was typed as an A23, and if I was given the choice to get a donor that was an A1 or an A24, which donor should I take? Anyone, which one would you take?
A1.
Okay, so A1's slightly different though. See how A23, the yellow region that's the same, is almost the same as A24. If I was an A23, would I take the A1 or the A24? Darren Trulevin says A24. And he's right, I would take the A24. If I was an A25, would I take an A1 or would I take an A26? Look at this green region. This is an area where an antibody can, this is an epitope. This A25 is very similar to A26. If I had a choice between an A1 or an A26, and I was an A25, I would take the A26 because it's more similar to me. And same goes here with A66, A68, and A69. There's more similarity here than there are differences compared to the A1. So this is what we're talking about epitopes. See how, if we were to talk about antigens, if you look at an A23 and an A1, you would say they're an antigen mismatch. An A23 and an A21 are not the same. That's a mismatch, right? And we would also say that an A23 and an A24 are a mismatch, would we not? We would say they're an antigen mismatch. We would say that they are an antigen mismatch. But from an eplet perspective, they're more similar than they are different from an eplet perspective. So there's a bit of nuance here. There's, antigens, looking at antigen mismatching is kind of a broad way of looking at things, but it doesn't tell you exactly what's going at the amino acid level. And there might be more similarities than you think. Okay, this is exciting, right? How does this translate into medicine? So we're going to focus on DR and DQ. And here we would look at these two recipient and donors, and we would say this patient and spouse are a complete DR-DQ mismatch, okay? Because they're not matched at all at the antigen level. But what about at the epitope level? We can go into this HLA matchmaker and we can actually look at them at the amino acid level and see if it's actually as much as a mismatch as we thought. So now that we have this data, in the last few minutes, I'm cognizant of the time, Dr. Ganji, don't worry. We're gonna go through now this paper, which is going to kind of dig into this. And I want you to think of these concepts, and we're going to walk through this paper and think about antigen matching versus eplet matching, and really how that actually fits into de novo DSA production. If you are a mismatch at the antigen level or at the eplet level, you may be at higher risk of developing de novo DSA, especially at DR and DQ. So this is a group from the University of Manitoba here in Canada that looked at 596 patients from 1999 to 2015 and over 50,000 tacrolimus levels. And what they did is they looked at these 600 patients and they categorized them into whether they were at a 1 DR mismatch or a 2 DR mismatch, right, at the antigen level, or a 1 DQ mismatch or a 2 DQ mismatch at the antigen level. They then did that calculation through the HLA matchmaker and looked at the variability in the eplets. So here, you can see here that these patients that were a 1 DR mismatch, yes, they're a 1 DR antigen mismatch, but when you look at their eplets, when you look at how they look at the amino acid level, there's a huge variability. Some of them had a very low eplet mismatch. Maybe they're an A23, A24, in this case, a DR7 or a DR8. They were more close than we would think at the antigen level, and some were very mismatched at the eplet level, up to 30 mismatches. So from 0 to 30 mismatches at the eplet level. And so what this is telling us, that using the antigen approach doesn't tell us the whole story. There's some large variability here, where even people that are a 2 DR mismatch may actually be better matched, for example, these people down here, than someone that's only a 1 DR mismatch. Okay, so how does this translate into outcomes? So they looked at people that were basically at the antigen level a DR or a DQ mismatch. So a 2DR, a 1DR or 2DR mismatch at the antigen level. And what they found was that when you looked at de novo DSA free survival, so basically looking at the people that actually produced de novo DSA, there was no difference whether you were a 1DR, a 2DR, or a 0DR mismatch. No difference. So we couldn't use antigen mismatching to predict who was going to make de novo DSA. Didn't help us. But when we looked at epitope mismatching instead, when we said, forget about antigen mismatching, let's look at the epitopes. Let's look at that amino acid sequence and see whether or not that predicts for de novo DSA production. What they found was that in people that had 11 or more, so 12 to 41 epitope mismatches at the DR or DQ locus, they were at higher risk of developing de novo DSA. Significantly, statistically significant difference in de novo DSA production if you have more than 11 eplet mismatches, if your epitope load is greater than 11. Any questions about that? This is a kind of a key slide. No? Okay. So now we're thinking, oh, geez, maybe we should be looking at epitope matching, right? We should be looking at this, and it gives us a bit more information than antigen matching. But what about the type of drug they're on? So this group also then looked at the same cohort and said, what was their risk of developing de novo DSA if they were on cyclosporin versus tacrolimus in blue? And there was a 3-fold increase, 2.7 times increased risk of developing de novo DSA if you're on cyclosporin versus tacrolimus. What about, is there a level at which you were more likely to develop de novo DSA if you looked at tacrolimus levels? And the answer is yes, it's right here, 5. So this is why Dr. Trelevin is saying tacrolimus level of 5 to keep your graft alive. He didn't really say that, but I feel like he's going to in the next session. What they've seen is that in people that develop de novo DSA, they more likely were to have tacrolimus levels less than a threshold, and that threshold is really 5. Anything less than 5, you are more likely to have a de novo DSA production. So when does that happen? This is really interesting. People that develop de novo DSA were more likely to have a low tacrolimus level 6 months prior to developing that DSA than a year ago. So if you looked at people here in basically greater than 6 months, less than 6 months, and no DSA, people in the red were more likely to have a lower mean tacrolimus trough and develop a de novo DSA within 6 months of their low tacrolimus level. So if someone has a low level, it's really in the next 6 months, this is when we can start seeing some graft dysfunction and problem. And this is the really cool part. It's not just the tacrolimus that's telling the story. People that were at high alloimmune risk. What is a high alloimmune risk? The people that had an epitope load of greater than 11. Those that had an epitope load of 12 to 41 were at the highest risk of developing de novo DSA with low tacrolimus levels. This was independently associated, meaning that it wasn't just the tacro level, it wasn't the epitope load, but the epitope load actually modulates the effect. Those with that high epitope load are particularly at risk of developing de novo DSA with low tacrolimus levels. So I hope that what we've gone through today is really that there's different ways of assessing immunological risk. But for today's discussion, when we're talking about de novo DSA production, we're really talking about matching at class 2, not only at the antigen level, but maybe more importantly at the epitope level. And maintenance immunosuppression can be tailored to all. We want to keep tacrolimus levels, at a good level, greater than 5, as we've kind of alluded to in both of our talks and all of our recipients, but, particularly in those that have a high epitope load. And I haven't gone into this paper here today just for sake of time, but there was a new paper that was published in AJT in 2020 from the Colorado group that was in the US that collaborated with the group at the University of Manitoba. And they also looked at several hundred patients. And what they found was that in those with a particularly high epitope load, we should really be targeting levels more close to 8 with tacrolimus. And it's really that high DRDQ epitope mismatch that is consistently coming through in various cohorts now to show that they have higher risk of de novo DSA production. So we've gone through the objectives of immunological risk classification and reviewed how to categorize immunological risk and the impact of tacrolimus levels on de novo DSA. And at this point, I'm going to stop here and ask if anyone has any questions.
Great, thanks very much, Christine and Darren. So I think Ali has a question there.
Yeah, thank you, Christine. Thank you, Darren. I have one comment and one question. So one comment, I think I will be on the side of DT for supporting a better higher TAC level. I think because of two reasons. One thing is when we speak about adherence in a transplant, it's different than adherence in any other clinical setting. For example, in any hypertension studies, for example, they require 80%, for example, of adherence, as opposed to transplant that we need 100% of adherence. So who knows, those patients, if we target a lower TAC like 4 or 4.5, if they are not adherent, how low it will be, and that might create lots of variabilities. The other point that what Christine mentioned, in practice, I think, and this will get me to the question to Christine, in practice, I think we're still far away, at least in Saudis, from iblet matching. So again, who knows, this what so-called low antigen mismatch might have a very high load of iblet mismatch, and lowering the TAC to lower level will result into bad outcome. So that's my comment. So Christine, how far you think it's applicable in the clinical setting to adopt iblet matching as opposed to antigen?
Yeah, it's a very good question. So, you know, even though we have this literature now, we're not routinely doing this in Canada either. It's not like we have like a calculator that is, you know, or a score that's assigned to every single patient. And in fact, there's a large study that's underway now across Canada with all the HLA labs in Canada looking at this to link it to clinical outcomes. So, you know, I think what's going to happen, Ali, is that in the next few years, there likely is going to be a calculator that people are going to be able to use. And in addition to your typing, your CPRA, your cross-match results, and your antigen mismatch, you're going to get a score that's going to probably tell you what the eplet mismatch is. In order to do that, the reason why not everybody's doing it across the world yet is that you have to do high resolution next generation sequencing to be able to do that. Because like, as I mentioned, we're really looking at single amino acid differences that help you calculate that eplet load. And here in Hamilton, we just applied and got funding to actually move to next generation sequencing. So in the next 6 months, we actually are going to have next generation sequencing. So it's up and coming. But you know what you might say, well, what can I do now? If I can't do eplet matching, what am I going to do now? This all sounds great, but what do I do for my patient in front of me? So what we've been doing, and what I think you know all of you remember as well, is that we are still using at least the antigen as kind of like a surrogate marker, because it's still, we know that if you're a 0DR 0DQ mismatch, that is better than being a 2DR 2DQ mismatch. So using even the antigen information gives you some idea of how risky is this person for developing de novo DSA, and how, you know, we always counsel our patients to take their medications and do their blood work, but those are the people you really want to stay on top of.
Great, thanks. Thanks, Christine. Darren, I'm going to have you ask a question. Just have one question to ask, and it's about the study that is from Manitoba. So what's the role of induction therapies, Christine? Because Manitoba is a non-inducing center. So they start off just with TAC. And would that be the case with the rest of the centers in Saudi? Would you be inducing or non-inducing centers? Like with ATG or basiliximab?
I think in our center we have adopted for the last 4 or 5 years ATG induction with a steroid-free protocol for the low-risk patients. So I think, and my colleague can comment, but most of us are inducing centers.
Exactly. Most of us are inducing. I never heard of any center in Saudi Arabia that is like universally not inducing their patients. So mostly inducing centers.
Yes, that's correct.
That's right. Yeah. So, I mean, I know that, so I'm not sure what the role of induction is. Maybe the Colorado study, Christine, maybe they had more data because most likely that was.
Yeah, they didn't look at that, Azim, because they're more focusing on de novo instead of like acute antibody rejection. And although you're right, induction may have a role in that, but they actually didn't, both studies didn't focus on that. They focused more on maintenance immunosuppression.
Okay. Thanks, Darren.
Thanks. I just wanted to just show another set of, like a quick set of slides just to support what Ali was getting at. And I just wanted to make a plea for trying to think in terms of probabilities and not think in terms of just absolutes, right? So I'm not sure if you can see this, but basically this is a typical patient's tacrolimus level as they go from inpatient to outpatient with a hip fracture. So the red line is 5, keep them alive, nanograms per ml. And you can see as this person gets hospitalized, where the red arrow is, all of a sudden the levels start to fall below 5. I mean, the person's older, they might be 80, they've had their graft for 20 years. But it really doesn't change anything about the sharks beneath the surface that Dr. Ribik was talking about. If you think about this from a probability standpoint, you have a lot of noise that is going into the distribution of tacrolimus levels in your patient. And some of it is bias because of people's intention based on their direction of care. So for example, they might want lower levels because the person is septic or old, or because they don't want to have cardiovascular events. But really, unfortunately, the patient is experiencing a normal distribution around 5, which exactly to Ali's point is that when you're not looking or they skip a dose, the level drifts down. And so if it's above 5, you're cool. But if it's below 5, you're not cool. So you can improve this by being purposeful and eliminating some of this bias and maybe moving the levels up. But you can actually eliminate some of these low levels too by just being a lot more precise about the levels you're targeting and changing the standard deviation or coefficient of variation in these patients so there are fewer levels that fall below 5. So it's just a plea to sort of think about this in terms of probabilities and not really in terms of like what their level is that day. Exactly to Ali's point.
Yeah, and I would, there's a lot of variability just within testing itself as well, right? So a lot of inaccuracies there. So, as at least for the guys that work with me, right? Remember, you're not allowed to change your level dose based on the actual level you see. You always look at the book and see what the last 5 or 6 levels are, and so you get the variation there as well. So, and that's a great point that you make. Oh, Darren,
the lower the levels is EM2, the less safety margin you have, right?
Exactly. Yeah. Exactly.
And and I would say too, I think it was Sultan that brought up the case of like, what do I do with this person whose levels are always low, and that person has probably declared themselves if they've been like that for a few years, and we may not really understand why they're okay, but we can't really pick out. The epitope matching is important to look at, but it's not like we can actually pinpoint who's going to be able to tolerate that. And more often than not, they're not able to tolerate. And what we're seeing is that they're having these subclinical events that we're not even seeing, de novo DSA production, that may be causing chronic allograft nephropathy and damage that we really don't have great treatment for.
Thanks, Abdurrahman.
Yeah, thank you, Rubik. Thank you, Trelevin. It's like nice presentation. Just similar to the Sultan case, which you just mentioned. I just remember a patient who missed her tacrolimus for 1 month, She ran out of the drug like during the COVID period. She's living far away. And when she came after 1 month, her FK level is less than 2, her graft function is totally perfect, and urine analysis is no protein, nothing. So when I go back to her HLA typing with her donor, it was just perfect match, zero mismatch at all antigens level. Of course, we don't have the applet match yet. So that's why I think we are usually dealing with a lot of uncertainty in transplant. We need to be safe. I will not be comfortable in keeping patient with FK level is 2 or 3. I will go to the safe margin above 5 all the time, regardless the match. But again, yes, there are like terminology we are using, which is maybe there is underlying etiology which we don't know. For example, immune tolerance. We don't know exactly what immune tolerance means, how long it will take to develop immune tolerance. But I think usually there is factors behind it. For example, the applet match. If there is like perfect match, immune tolerance will be the definition which we will use, regardless the real immune tolerance, which will not occur in any patient. Again, if patient has perfect match, but he has mismatch at any antigen, trigger may happen anytime. So I'll not feel comfortable to keep FK level is less than 5. I mean, patient is not equal, but again, we are dealing with a lot of uncertainty.
I totally agree with you, Dr. Altaibi. I think you've summarized the talks perfectly by what you've just said, you know. I do not feel comfortable keeping anyone less than 5, you know, given the information that we have. And in fact, it looks as though there are some people that we may even have to run higher than that. So we cannot identify who these lucky people are that are perfectly matched across applets. And it's really like a bit of a gamble if you're going to try to keep them less than 5. So thank you for summarizing that so well. That's exactly our sentiments. We're all on the same page.
Yeah, because the other thing, Abdurrahman, I think, is that you don't know when those cytokines are going to change. So you get another hit, and then the game is over. So that so-called tolerance disappears very quickly. They get an infection. I think Darren had mentioned that too earlier. Something immunologic occurs, and then your tolerance is gone, and then the low TAF level will display itself as being inadequate.
Wait for trigger.
Exactly. Yeah. Just like that, you know, every other hypothesis that occurs, whether it be PKD, whatever, it's an additional hit that you need to change things around quickly.
I just want to mention one thing. I think Abdul Rahman, you were with us when we had, I'm trying to remember if you were there, but I think you were. We had a young lady who Dr. Trelevin's actually going to try to work up now for transplant, who was perfectly matched to her aunt. And she actually rejected her kidney. So, you know, and it was because she had a situation where she had some mental health issues and, you know, was not taking her medications, had run out of drug, and she rejected her kidney. So even when you think at the antigen level, people are perfectly matched, you know, there's still things lurking there and they can reject.
Yeah.
Great. Any other questions? Or comments, Mohammed?
Yeah, thank you, Dr. Ribik, and thank you, Dr. Trelevin. Dr. Ribik, I have a question. It's actually not about the epitope mismatch or epitope load. It's about the PRA. Actually, after looking at what you just presented, that PRAs, the CPRA is not associated with graft loss, rejection, or all the major outcomes in transplantation. The question is, what's the benefit of doing it to start with? I mean, I can understand that for if I'm working a patient for deceased donation, but for most of our patients in Saudi Arabia, we are assessing our patients for living unrelated kidney transplantation. So, I mean, what's the value here of PRA, CPRA in these cases?
Yeah, no, it's a great question actually, and it's very insightful. So, you know, PRA is really kind of a measure of your ability or
to find the donor.
Yeah, to find a donor, exactly. What are your chances of finding a donor, right? If you have a high CPRA, your chances are going to be less. So, you know, in our lab, we actually don't do PRAs on people because it doesn't really tell us anything, only if it's a cheaper test than an antibody identification test. So if your CPRA is 0, what we do in our lab is we do a PRA twice a year and an antibody identification once a year. But what else do we use the PRA for? So in Canada, and I'd be curious to see if this is, you know, what you would be doing as well, but we use it to actually help in the allocation of kidneys. So if you have a higher CPRA, because your probability of getting an offer is much lower, it's going to move you higher up the list. The other thing is that if you have a high CPRA and you have a breach in immunosuppression, you know, theoretically, you have shown that you're able to make antibodies. We all know people that have been pregnant 5 times that have no antibodies. And we know people that have been pregnant once that have 100% CPRA. Everybody's different. So if you're someone that has a high CPRA, it just tells us that if you have a breach, you're more at risk of having these bad things happen. So really the answer is your probability of finding a transplant and where you're going to be on the list.
Thank you.
Welcome.
Abdurrahman?
Yeah, can I add just one point to Mohammed's question? Because we are doing the same. PRA is cheap. That's why we are doing it as a screening before we go to cross-match. Sometimes PRA will show you virtually there is positive cross-match. So you don't need to proceed for physical cross-match. You just save that like highly costly test. And in addition, for
patient test, Abdurrahman is well enough to.
You mean single antigen antibody?
Yeah, you're talking about single antigen. Yeah.
Yes.
Yeah. You're right, but the PRA would be, like you said, Abdulrahman, it's a screen maybe up front just to say, oh, geez, you're 100%. Like, I don't think we're going to find you a donor anytime soon, or you're 0. Anything works, you know? Yeah.
The other way it might work as well, in the sense that if you're like 80 or 90% PRA and you get a kidney, most likely you'll be pretty well matched because you've obviously knocked off everybody else on the potential donor list. So that might even give you an indirect idea. And that might be coming across in the data as well as to why the high PRA patients do well, is there might be a higher risk of matching just because you almost have to find somebody very similar to you.
Yeah, very, very similar or very different. Those are the 2 categories. So someone that actually has really rare typing or is a haplotype, is like basically only has like a single haplotype. So instead of having like an A1 and A2, they're an A2, a B42, like just one typing across without actually like 2 haplotypes, only 1 haplotype. So yeah.
Okay, excellent. Any other questions? Okay, we want to just get your feedback on a couple of things. So I'm just going to share my screen here. And really, the idea over here was to get some ideas on future topics and engagement with you guys as well. So we were planning to do a kind of a session on pharmacokinetics of tacrolimus and some other different formulations that you had access to and how to work with those. Another topic was non-adherence to transplant immunosuppression, remote transplantation clinic, kind of where we went through COVID, and remote patient monitoring, and sharing the Canadian experience, and then review of transplantation immunosuppression protocols, and really kind of looking at things like CNI avoidance and withdrawal or minimization versus optimal TAC exposure. So those are some of the things we had. I think we're pretty flexible in these topics. So what do you guys think? What do you guys feel is a more important need otherwise?
If I'm allowed to speak, Ganji, I think maybe if we can add also within the different various formulation, you mean it's not only the short or long one, it's also the brand one, whether it's brand or generic, and switching one patient from one brand to another brand. I know there are a couple of articles talking about change in interpatient variability or coefficient of variation. I think this will be one important thing to discuss. And the other one, what DT did mention about within the immunosuppression management protocol during solid organ malignancies, plus minus sepsis or severe infection.
Okay, those are actually good topics. And so yeah, we can. So we would say session 2 would be that, and maybe we can broaden that out. Maybe we can also include like maybe TAC testing, different types of assays that are available for tacrolimus testing that might throw us off as well, depending on which lab it's done in as well, right? And we can talk about the malignancy and infection. Anything else, Mohammed? Oh, you're on mute, Mohammed.
Mute.
You're still on mute, buddy.
Okay, can you hear me now?
No, you can't.
Okay, great. So, I'm just wondering if talking about desensitization protocols would be out of the scope of these talks, or we can talk about it a little bit regarding those with DSAs, those with cross like positive cross match. So
we can talk about anything you like. Let's put it that way. I'm saying that as I look at our hosts as well to make sure that that's true. Is that true? We can talk about anything they like.
Sure thing, of course.
Okay, excellent. The reason why, you know what, I wonder, I don't know, tell me what you guys think. Maybe we can talk about desensitization, not so much desensitization, but crossing DSA kind of in the new era, where we're looking at maybe like the willing to cross, where we're crossing DSA, but it's not that like super, super, super high risk. It's kind of like intermediate risk, where you have a previous DSA and cross matches negative, and maybe how to interpret cross matches. We can do something like that if you like, just because, you know, there's gradations of doing HLA incompatible transplants, and you may want to start with something that's not so high risk, because we've moved away from doing high risk just because the outcomes have not been as good.
So
yeah,
Mohammed,
it's interesting, very interesting here in Saudi Arabia, because the disease donation is not as common as in Canada. So quite often you would transplant somebody after desensitization protocol. So and currently, I have a patient who is under desensitization protocol, hopefully for transplantation tomorrow. So yeah, so this is why I think it's
we can add that for certain. We can do that for one session. If others would like to hear that would be fine with us.
Yeah.
Can I add one point?
Sure.
About management of chronic antibody-mediated rejection, because this is one of the topic I think the most needed, especially for those with long-term transplant. In addition to the point was added by Dr. Ali Shaggag, the management of immunosuppression during malignancy and sepsis, because this is the most challenging area for the transplant nephrologist, because I have plenty of patients with chronic antibody-mediated rejection, and we know the treatment during the acute setting, it's like plasmapheresis, IVIG, but what about the chronic one? How I can prolong their graft with the presence of this DSA in their system? Thank you.
Yeah, that's a good point, a good topic, and a challenging topic, right? So we can certainly discuss that. And then Mohammed, we can certainly discuss the desensitization protocols the way you're doing it, not the way that it is being proposed in Canada, because it's a very light way of doing it. But we can definitely discuss the history of the other ones that we've done, but how we moved away from it, because the outcome has been kind of variable, as you well know.
Yep.
So that's great. Any other topics?
I think what Dr. Mobi saying is very important, because Christine, here we have to cross DSA. We have a highly sensitized population. Our KBD programs are not mature yet. We are only at a center level, not even at a regional or national level. We're still working on this. And we have a lot of patients with DSAs and negative cross-match. And I have one study actually that it's in the writing process of our experience with patient with weak DSA, pre-transplant weak DSAs, and their pharmacodynamics after DSAs and their risk of rejection. We have 117 patients over 6 or 7 years, I can't remember. The risk of rejection was 12.8%, whether they receive IVIG pre-transplant or not. But we have identified some certain group, that those with female group, those with any DSA above 1,000, because here they identify our lab DSA week 1 below 2,000 MFI and weekly activity below 1,000. So anyone above 1,000, or if there is an increase post-transplant by more than 1,000 upon routine screening, or any de novo DSA, put them at higher risk of rejection, though 3 years patient and gross survival were similar to those who does not have rejection, like among the 117 patients. So
yeah, definitely. I think we can certainly look at that. I think what you know, it's interesting. You've mentioned a few things here. So even in HLA incompatible transplantation, you know, there's different gradations of what you're going to do. I think, you know, crossing like a high level class 2 antibody that's current with a positive cross match that remains positive at serial dilutions is something that not many people would want to do, because we know it's going to probably not end well. But we can talk about kind of strategies, you know, and how to kind of do high risk transplantation that's HLA incompatible, but maybe on the lower risk side or medium risk side. So we can kind of define what that might be. And when you mentioned DSA positive cross-match negative, that's exactly the group that we're going to be doing in the Willing to Cross. So, yeah.
Can I ask Ali? I mean, when was the last time you transplanted somebody after desensitization? I mean, I know that you are working in a big program, and I would expect you to do like 5 or 6 patients per year, if at least minimum. Like after desensitization.
No, go ahead, Ali. Yeah.
Probably prior to the KBD, which was back in 2016, there was a lot of crazy desensitization happening with a very strong DSAs even, and sometimes they cross-positive cross-match with IVIGs and TBEs, pre-post. Nowadays, I can tell you in the last at least 4 years since I came back from Canada, we do cross-weak DSA as an identified by weak to moderate, even below 3,000 MFI, but negative cross-match. We don't do positive cross-match. And we still do ABO incompatible. That's because we have the KBD luxury, although again, it's a center.
Despite the KBD program, I mean, how frequent do you desensitize?
That's what I'm saying, Mohammed. We don't desensitize anymore.
Okay.
Except the week 1, we give them just IVIG if they are class 2 or second transplant or other risk factors. But we don't do it.
Yeah. And Ali, remember we did those before we did the ABYs, but previously, you know, we used to do those high risk ones where you have the high usually class 1s, to be honest. Class 2s are very difficult to cross. And you get the variability of the results, right? You get the rejection up front earlier, but then you don't get the chronic rejection with the other ones. You get the chronic rejection with the class 2s. And you're right, like the weak flow cross matches are usually, you know, relatively speaking, especially class 1s are not too difficult to cross, right? So I think it's a gradation as opposed to an absolute no, right? Especially when you're looking at the patient's risk of being on dialysis and stuck on dialysis forever as well, and their age. So, okay, that's great. So I think we've got a few more topics here, so we can kind of review these and then come back with some of these, and then we'll shift some of these topics around as well. I wanted to just put in a plug for one other thing over here, which was, oops, we don't need to do that, is the CST part. So one of the aims for the Canadian Society of Transplantation is really to kind of increase collaboration with especially the Saudi trainees, especially given that most of you guys as faculty and staff people now practicing transplantation, a lot of you have trained in Canada. And so we kind of wanted to bring that group back in again. And this year, and chairing both the fellow symposium and the AGM, we're really trying to make a big reach out. And I think I've talked to Abdul Rahman a bit about it, to Ali and to Mohammed as well. But hoping that we can develop a relationship where you guys can also come to the CST. So I think probably best to, I think I was working with Abdul Rahman and to kind of try to sort that out. So hopefully we'll get that out, and then we'll get you some information through Abdul Rahman if that's okay with you. Is that okay?
Yeah.
Excellent. Great. If you guys have any other ideas.
At least we can meet at La Luna with the next meeting, and then we can decide. No problem.
Absolutely. Yeah, there's a virtual component to this as well. So if you can't make it down to La Luna's, that's okay. That's funny. Okay, and I think I'm going to make sure. So just want to thank everybody for joining in. Big thanks to Christine and Darren for doing fantastic presentations today. So thank you very much, guys, for doing that. And thank you all for joining in. It was a fantastic and great conversation, especially towards the end. And thanks for all your suggestions over here. And once again, thanks again to all the sponsors for helping and allowing us to present and hook up with our colleagues in Saudi. Great. Any other last comments?
Thank you very much.
And Bahar?
Yes, thank you very much all for being here. I have a last minute question, if you may. It was difficult to arrange this meeting because of the time zone difference. I know we started like noon at Canadian time zone, 12:30 at Canadian time zone, and 8:30 p.m. in the Saudi time zone. Is this the best scenario for everyone, or we can manage some different timing for the next meetings for proper or more easier arrangement? Do you think if anyone have a better suggestion, we can reflect that in our next meeting?
Do you guys want to start a bit earlier, so because it's not so late for you? I mean, we can always go back to, for us it's easier. It's only only 3:30 now, so we can go up earlier.
Because we started at 1:30 here, so I agree with Azim. We can start earlier.
Yeah.
What's good for you?
For me, I think this time is good. I don't know about the other guys.
I think it's good also for me here.
Yeah, I think it's great.
Yeah.
So we have 3 time zones in Saudi Arabia, so East, West, and Central. So we are perfect with all. Yes, that's all for me. Thank you very much, and appreciate your attendance here today and the discussions and everything.
Excellent. Okay, that's great. Okay, thank you very much again, everybody, and look forward to seeing you in September. I think is our next one. Okay.
Thank you.
All right. Okay.
Take care, everyone.
Everybody, have a great day.
Bye.
Bye. Night.
Thanks. Bye.
Bye. Nice to see you all.
Bye.
Thank you for attending. Good night.
Bye.
Good night.